Hi friends, today we will talk about oral incretin therapy. First is the disclaimer. This video is made for educational purpose only. There is no endorsement for any brand or company. Before understanding about the oral incretin therapy, let's discuss about the incretin. Incretins are basically gut derived peptides, or we can say they are metabolic hormones. They are released from both upper and lower gut in response to the food intake, especially the food rich in carbohydrates and fats. They belong to glucagon superfamily, but the action is totally different from glucagon. They stimulate glucose dependent insulin release from pancreatic beta cells and also inhibit the release of glucagon from alpha cells of the pancreas. GLP-1 and GIP, these are the two incretins which are released from the gut. GLP-1 means glucagon-like peptide 1. It is secreted by L cells in the distal ileum. And GIP is the glucose independent insulinotropic polypeptide. It is secreted by K cells in the proximal intestine. When the food is ingested, the glucose in the food, or we can say the end product of the food, that is glucose in the intestine, it causes secretion of GLP-1 and GIP, which in turn stimulate pancreatic beta cells, and pancreatic beta cells, in the pancreatic beta cell there occurs synthesis and insulin secretion, and overall there is increase in pancreatic mass by decreasing the apoptosis. It means that incretins, though they stimulate insulin secretion and synthesis, they also increase the pancreatic mass by stopping the apoptosis. GLP-1 also suppresses the glucagon secretions, and GIP slows the gastric emptying and increases the satiety, and therefore it promotes the weight loss. Incretins, they have multiple actions on different organs. In the CNS, they increases the synaptic transmission. They have a nerve protective effect. They increase the memory. They decrease the learning defects. They cause the proliferation of the neural stem cells. They improve the memory. They prevent the neuroinflammation. Motor function is increased, and the signal level of the satiety is also increased. In the heart, they have a cardioprotective action. They increase the heart rate. They have anti-inflammatory properties. Myocardial ischemic injury is prevented. They also decrease the endothelial dysfunction. They cause lipid lowering, and they also increase the secretion of the ANP, that is atrial natriuretic peptide. In the liver, they decrease the glucose production. They have they decrease the content of the fat in the liver. Plasma liver enzymes, they are also decreased, and they also prevent the hepatic steatosis, or they decrease the hepatic steatosis. In pancreas, besides increasing the insulin synthesis and secretion, they increase the beta cell proliferation, and they have a protective effect on the beta cell. In the gastrointestinal tract, they reduce the gastric emptying, and they also decrease the GI peristalsis. These endogenous GLP-1 and GIP, when they are secreted by the intestine, they are rapidly degraded by the enzyme which are present in the endothelium of the blood vessels of the intestine, and this enzyme is DPP4, that is dipeptidyl peptidase type 4. These enzymes causes the breakdown of the GLP-1 and GIP within few minutes after they are released from the intestine. So very small amount of the intestinally secreted GLP-1 and GIP have these incretin effects. So the drugs which inhibit the DPP4 enzymes, they will increase the concentration of these endogenous GLP-1 and GIP, and therefore they will these drugs, by preventing the effect of DPP4 enzyme, and they will increase the concentration of endogenous incretins, which will in turn cause increased insulin synthesis and the release. So in this diagram, we can see that incretins, they stimulate the insulin release and hence lower the blood glucose. They also inhibit the glucagon release and hence lowering of the glucose. The DPP4 enzymes, they cause the degradation of the incretins. When they will cause degradation of the incretins, the insulin release will be inhibited. It will lead to increased blood glucose, and the DPP4 inhibitors, the drugs which block these DPP4 enzymes, that will cause increase in the endogenous GLP-1 and GIP, which will in turn will lead to increase insulin release and inhibit the glucagon release, thereby lowering the blood glucose levels. Oral incretin therapy includes DPP4 inhibitors and GLP-1 analogs. DPP4 inhibitors, they act by increasing the endogenous incretin hormones, and oral GLP-1 analog, for example, semaglutide. It was approved in 2020. It is the first oral GLP-1 analog for type 2 diabetes mellitus. This GLP-1, oral GLP-1 analog, that is semaglutide, it is exogenous GLP, and hence it is resistant to degradation by the DPP4 enzymes. Let's discuss about the DPP4 inhibitors. They inactivate DPP4 enzymes, and they act in part by slowing the inactivation of glucagon like peptide. Since they inactivate DPP4 enzyme, so there will be the inactivation of the GLP uh, incretin will be prevented, and it will lead to increased concentration of the GLP-1, and which are generally decrease in type 2 diabetes mellitus. And when these GLP-1 are increased by the action of the DPP4 inhibitors, they will help in reduction of the blood glucose. So the DPP4 inhibitors, they target mainly the postprandial blood glucose excursion, but they also reduce the fasting blood glucose. They stabilize the endogenous GLP-1 at a physiological concentration, and hence stimulate the insulin secretion in a glucose dependent manner. Therefore, they don't cause any hypoglycemia. The effect of DPP4 inhibitors on weight is nil, that is null. They are weight neutral. They reduce the postprandial blood glucose by 40 to 60 milligram and fasting blood glucose by 15 to 30 milligram, and hence they cause the reduction of HbA1c by 0.7 to 1%. More the baseline HbA1c, more is the reduction. So because of their effect on postprandial blood glucose and also the fasting blood glucose, they are also considered second line drugs in the treatment of type 2 diabetes mellitus, but they can be given as a first line in patients who can't tolerate metformin and patients who have hypoglycemia with other oral anti-diabetic drugs. Reduction in HbA1c is more if the baselines are higher. They can be combined with other OADs or insulin. They are safe and efficacious in NODAT, that is new onset diabetes after transplantation. Few DPP4 inhibitors are also called gliptins. Examples are Sitagliptin, Sexagliptin, Linagliptin, Vildagliptin, Teneligliptin, Allogliptin, Gemigliptin. Sitagliptin is available in the market as a Januvia. It comes in a dosage of 50 to 100 milligram. Sexagliptin, this is not used because of increased risk of heart failure. Linagliptin available in market as Ondaro in a dose of 5 milligram. It is not excreted by kidney, so it's safe in kidney patient. The Vildagliptin is available as 50 to 100 milligram. Teneligliptin is available as 20 milligram. Allogliptin, it is also not used commonly. Gemigliptin is another gliptin. The first developed drug was Vildagliptin, and but first marketed drug was Sitagliptin. Teneligliptin is of Indian origin. All these gliptins or DPP4 inhibitors are given on once a day basis except the Vildagliptin, which is given as twice a day basis. CKD patients requires the dose reduction of these DPP4 inhibitors. Linagliptin is very safe in CKD and it can be given in full dose. Vildagliptin and teneligliptin can be given in smaller doses. And they control postprandial blood sugar very effectively in CKD patients. They have very lesser or no risk of hypoglycemia. They have very good tolerability. They are not as potent as sulfonylureas in rapidly reducing the blood glucose because sulfonylureas cause rapid reduction in blood glucose. They are so these DPP4 inhibitors they are not as potent as sulfonylureas. Side effects of these DPP4 inhibitors are headache. Few patients have allergic reaction. Patient can have joint pains, increased risk of heart failure. The increased risk of heart failure is seen with the sexagliptin and allogliptin. These gliptins or DPP4 inhibitors are to be avoided in type 1 diabetes mellitus, pregnancy and lactation, diabetic ketoacidosis, and in people less than 18 years of age. This was about the oral incretin therapy, and in oral incretin therapy I talked about the DPP4 inhibitors. In next video I will talk about the another oral incretin, that is the semaglutide. Thank you very much.